welcome to a new session of clinical pharmacology. Today we are going to speak about cyclooxygenase COX-2 inhibitor. I'm Dr. Khalid Hassan, professor of clinical pharmacology, drug therapy, and clinical research. Okay, in this slide, we can see the list of medication belong to the selective cyclooxygenase COX-2 inhibitor, which end up with the Coxib. So we have the prototype, the first medication, Coxib, brand name Celebrex, followed by Coxib. Then we have Coxib, Valdicoxib, Rivocoxib, Coxib. So we can see here we have 6 Coxibs available. However, we have only 2 medication in the clinical practice in the US. Coxib, as you can see, it's here. We have Coxib currently available for the practice. Coxib available and approved for the clinical use. Then we have Coxib available as injectable prodrug of Valdicoxib. We use it before the surgery or perioperative use for surgery. So again, list of popular medications: Coxib, Coxib. Then we have Coxib, Valdicoxib, Rivocoxib, Coxib. However, if you look on the clinical use, we have Coxib in the practice available as oral, Coxib injectable prodrug of Valdicoxib. If you look on the Valdicoxib and Rivocoxib, Coxib is withdrawn from the market due to the cardiovascular risk. Okay, in this slide here, we have a quick reminder of the non-steroidal anti-inflammatory drugs. As you can see here on the left side, we have NSAID medication, group of medication belong to the over-the-counter, that mean available without prescription, such as ibuprofen, Advil, naproxen, Aleve. We have aspirin, then we have diclofenac, topical gel, 1% Voltaren arthritis pain gel. Speaking about the medication available with the prescription needed here, prescription only NSAID. Here we talk about Coxib, diclofenac, oral, diclofenac patch, meloxicam, Mobic, naproxen, high strength, indomethacin, endocin, ketorolac, etodolac. Continuing with the list of medication belong to the NSAID, we have nabamiton, oxybrasine, piroxicam, solindac, phenobrofen, floriprofen, meclofenac, mefenamic acid, and tolmetin, tolcotin. Okay, in order to understand the mechanism of action and how this medication work, and then at the end we have case study, several questions follow this short session presentation. As you can see here, we start with the cell membrane. On the cell membrane, we have a component called membrane phospholipid, and this membrane phospholipid present arachidonic acid as a first component for the formation of important mediators in our body, such as prostaglandin and leukotriene. As you can see here, we have enzyme. This enzyme called phospholipase A2, and this enzyme responsible for formation of arachidonic acid. Then arachidonic acid will follow two pathways: cyclooxygenase, which mean COX-1, cyclooxygenase 1, and we have cyclooxygenase 2. So as you can see here, we have cyclooxygenase 1, and then we have cyclooxygenase 2. So we have two main pathway, maybe coming from the arachidonic acid. If you follow the cyclooxygenase 1 considered like homeostatic or housekeeping, responsible for formation of thromboxane A2, responsible for gastroprotection, renal function. However, the thromboxane A2, this type of prostaglandin, this thromboxane A2 responsible for increased platelet aggregation and increased vasoconstriction. So this will keep the blood, maybe if you have any wound or something like that, thromboxane A2 will be activated and will be close the wound and create the clotting, blood clotting. Okay. On the other hand, we have cyclooxygenase 2, COX2, and this COX2, we have prostacyclin, and we have prostacyclin I2, and we have prostaglandin E2. Here for the inflammation fever, we have prostaglandin E2. So we have several type of prostaglandin. This one here, prostacyclin. Then we have prostacyclin I2, prostacyclin I2. Then we have prostaglandin E2. The prostacyclin E2 responsible for pain, fever, inflammation, and prostacyclin responsible I2. Prostacyclin I2 responsible on the opposite effect by decreasing platelet aggregation and induce vasodilation. Now we understand we have balance in our body between thromboxane A2 and the prostacyclin. So the question here, which of the following prostaglandin responsible for platelet aggregation? Increased platelet aggregation and blood clotting will be thromboxane A2. Which of the following prostaglandin responsible for decreased platelet aggregation and induced vasodilation? That will be prostacyclin, BGI2. Okay, next we are going to speak about site of action. Where is our medication work on this pathway from membrane phospholipid, arachidonic acid, cyclooxygenase 1, cyclooxygenase 2, after we understand the concept here. Start with the phospholipid. Again, we have the enzyme phospholipase A2, and this is responsible for formation of arachidonic acid, which lead to the activate cyclooxygenase 1 and cyclooxygenase 2. Okay, and cyclooxygenase 1 responsible for housekeeping and the platelet activation, renal function, gastroprotection, as you can see it here. However, another pathway from the arachidonic acid, we have leukotriene. Leukotriene responsible for formation of lipooxygenase enzyme and formation of leukotriene. Okay, so the first one here, we can see it. The first medication we use it in the practice, corticosteroids. When you speak about corticosteroids, here we talk about cortisone, cortisol, prednisone, prednisolone, dexamethasone, methylprednisolone, a list of medication. How the cortisone work, how the cortisone decrease inflammation, the main mechanism of action, follow the inhibition of phospholipase A2. So what is the mechanism of action? The main mechanism of action of cortisone in decreasing pain and inflammation. Corticosteroid inhibit enzyme called phospholipase A2. This will lead to the inhibition of lipooxygenase and arachidonic acid formation. Cyclooxygenase 2 pathway will be inhibited, the cyclooxygenase and lipooxygenase. Okay, moving to this is one medication here, and this explains the reason we use corticosteroid for asthma, because leukotriene will increase in patient with asthma. And when you inhibit the leukotriene through using a corticosteroid, we can use a corticosteroid inhaler for asthma, for example. Here, if the patient suffers from arthritis, pain, fever, we can use corticosteroid because inhibit this pathway. So now we understand why cortisone used for asthma, why cortisone used for inflammation or arthritis. Another important medication here, we have NSAID, and we are familiar now what is NSAID. As you can, if you remember the first slide, the beginning of our slides, we have ibuprofen, naproxen, we have meloxicam, Silocox, a list of medication, aspirin, and this is called NSAID. As you can see here, NSAID in general cannot differentiate between cyclooxygenase 1 and cyclooxygenase 2. NSAID in general inhibit both cyclooxygenase 1 and 2, as you can see it here. NSAID inhibit both 1 and 2. This explains why NSAID reduce pain, why NSAID reduce fever, why NSAID reduce inflammation, because inhibit cyclooxygenase 2. However, they found NSAID at the same time inhibit COX1, and COX1 responsible for gastroprotection and renal function and platelet activation. This will lead to the peptic ulcer alteration. This will lead to the peptic ulcer and gastric irritation. This will lead to the decreased renal blood perfusion and affect the platelet function. Okay, for this reason here, the pharmaceutical company start to present a new component, a new drugs that inhibit only COX-2. We don't like to affect the COX-1, and they present Celecoxib. As you can see here from the Celecoxib, uh, as you can see here from the Celecoxib here, Celecoxib selectively inhibit COX-2. So celecoxib selectively inhibit COX-2, reduce pain, fever, and inflammation without effect on the GI system, without affecting on the GI system or renal function and platelet aggregation. Okay, so this one will be good. So the question here, celecoxib will be the best option for patients from arthritis and peptic ulcer disease because there's no effect. The celecoxib does not affect the prostaglandin in the GI system. Okay, now we have some explanation, more explanation to understand celecoxib effect now. So we know that celecoxib, the best medication for patients from peptic ulcer disease and arthritis. What about a heart disease, cardiovascular risk factors? We have another slide here, another cascade we need to understand. As you can see here, phospholipid, membrane phospholipid, we have phospholipase, arachidonic acid again. We have two pathways, cyclooxygenase 1, cyclooxygenase 2. Okay, prostaglandin, thromboxane A2 is very important factor. We have prostacyclin on the other hand, and this will lead to the, you can see the balance here between prostaglandin, thromboxane A2, and prostacyclin. So we have balance here, like scale. We have balance between we have balance between two main mediator, thromboxane A2 and prostacyclin I2 here. Okay, so our medication here, when we use celecoxib, as you can see here, when you use celecoxib inhibit COX-2. Celecoxib inhibit COX-2. And if you go back again, you can see the balance here between the arrow. Between the arrow here, we have balance. But when you use celecoxib, you can see here we inhibit this pathway here. This pathway will be inhibited, and this will be lead to the compensatory activation of cyclooxygenase 1. Compensatory activation. Compensatory activation mean increased platelet and this will lead the shifting the balance towards COX-1 and enhance platelet aggregation. And this will lead to the increased activity of thromboxane A2. Therefore, the patient may suffer from cardiovascular risk, cardiovascular event, clotting, myocardial infarction, and stroke. For this reason here, we don't recommend to use celecoxib. Celecoxib not recommended to be used in patient with a MI, myocardial infarction, in patient with a history of hypertension, in patient with a angina. So we don't recommend to use this medication in patient with a history of cardiovascular disease. Okay, the case study here again, we have 62-year-old man with a history of hypertension, with a history of hypertension, a stable angina with a peptic ulcer disease. The patient suffered from chronic knee pain consistent with osteoarthritis. The patient previously used a diclofenac gel, topical diclofenac gel without adequate symptom relief. He asked about oral medication effectively relieve pain, joint pain, and given his cardiovascular history and increased risk of gastrointestinal complication, which of the following drugs most effective and safest option for this patient? Ibuprofen, celecoxib, diclofenac, or acetaminophen? Okay, so start with the first one. Ibuprofen is not recommended due to the history of peptic ulcer disease. Diclofenac the same due to the history of peptic ulcer disease. We don't recommend it to use it. And what about celecoxib? We don't recommend celecoxib because the patients suffer from cardiovascular disease such as angina and hypertension. So the best option here will be acetaminophen. There is no effect on the GI system or the cardiovascular system. We have, as you can see here, ibuprofen contribute to the peptic ulcer disease by decreasing production of which of the following endogenous agents? By decreasing production of which of the following endogenous agent? Okay, ibuprofen. What do you think? Histamine, castrin, prostaglandin, acetylcholine, or serotonin? Okay, so the correct answer here will be, when you speak about ibuprofen, we know that ibuprofen inhibits cyclooxygenase and cyclooxygenase is responsible for formation of prostaglandin. So the correct answer will be prostaglandin. Okay, this will conclude our brief session about cyclooxygenase COX-2 inhibitor. We explained the mechanism of action, the clinical use, and contraindication. And I hope to see you again in another session. Thanks so much and have a great day.